You know, when you say that you're on schedule, that pretty much means that you'll be knocked off schedule. So, but here we are. We're back on track again. We're waiting for one of our speakers who has joined us. So we're going to go ahead and start the next panel on health accessibility and disparity. And we have three wonderful speakers joining us today. We have Dr. Helen Hurst from the UL Lafayette College of Nursing and Allied Health Professionals, Africa Dauphiney from the St. Bernadette Community Clinic, and Judith Perez from the Lafayette Community Health Care Clinic also. So we'll give you guys the floor. Thank you so much for joining us today.
Good morning, and I speak very loud, so I don't need the microphone, so I'm good. And it's so great to see some of our nursing students here, and so many people who taught me, like Dr. Marianne Wilson, Dr. Carolyn Delahousie, and so all of you back there. I was just telling them a minute ago when I left here from nursing school, I said I'm never coming back. And now I've been teaching here since 2002. And 2 more degrees later, my husband's like, "You've done all the degrees you can do now because you really need to stop going to school." I'm like, okay, that's great. And so excited Dr. Farmer Kaiser and her book out there. That is so exciting that we have that. And should we get some men to come too and to come listen?
Hey, there are men who contributed to the volume.
Yeah.
They're fantastic. Michael's here.
Okay, so I could talk about health disparities in maternity care for like 3 hours. So cutting this to 20 minutes was kind of difficult. But what I really wanted to do is really kind of give you an overview. Because we think of here as the United States as having the best healthcare system in the world with the best outcomes. But when it comes to maternity care, we spend more dollars per person than any country in the world on maternity care, and yet we are actually looking at some statistics. We are only 37th in the world. We are the only country in the world where our maternal mortality rate is rising. So, we really have some serious issues, and I think it's something that we don't pay enough attention to. When we talk about, women's health care, we generally think about breast cancer, and we think about diabetes, and Africa and St. Bernadette's is doing so much work with the underserved population in relation to that, breast cancer, diabetes, colon cancer, but we're really not talking about our pregnant women and the things that are happening. So I really wanted to give you an overview kind of worldwide, and at the same time, kind of let you know what's going on here in Louisiana too. So dying to have a child. So the United States spends $98 billion a year on hospitalization for pregnancy and childbirth, but the maternal mortality rate has doubled in the last 25 years. And if you look in 2010, our maternal death rate was 12.7 deaths per 100,000 live births. In 2013, it was 17.8 deaths. So we are continuing to go up. And it was really interesting. I was looking at something this morning that compared childbirth in 1915 to childbirth in 2015. And you looked at the really differences, and Dr. Delahousie will really relate to this, that back in 1915, 70% of the births were done by midwives. 70% of the births were done in the home. Now, 90% of the births are done by physicians, and over 95% of the births are in the hospitals. And yes, people don't die of childbed fever anymore, but we're going to talk about the things that women really are dying of here today. African American women are 3.2 times more likely to die due to pregnancy and childbirth than white women. Okay? Many of these things are due to access to care, which we know is a huge issue here in the state of Louisiana. In Louisiana, over 80% of births are born to women who have Medicaid. That really says a lot about us as a state in that we are trying to support women who are pregnant, because many women, in fact, who are just like you and me, who may perhaps have insurance, but it doesn't cover maternity care. So we're seeing more and more women who have private insurance being able to get Medicaid, because even though they're paying all this money every month for insurance, it doesn't cover them to have a baby. In the African American population, we're seeing an increase in the number of women who, because of the lack of access to care for transportation, for whatever reason, don't understand how to get on Medicaid. And if you have ever looked at a Medicaid application, you kind of need a PhD in technology to even fill out the application form. that they can't get that, they're not getting prenatal care till the second or third trimester. So therefore, by that time, we're missing the things like gestational diabetes, gestational hypertension, the things that really have a negative impact. So, you know, we kind of talk a lot in the U.S. about pharmaceutical companies and how they aren't always maybe doing the best for us and they're out to make money. But Merck is a major pharmaceutical company, and they have participating in a 10-year, $500 million initiative worldwide on decreasing maternal mortality. And the United States is one of those countries that they're focusing on. So here's some really sobering infographic characteristics. It's the death of a woman from complications of pregnancy and childbirth, and the direct leading causes of maternal death in the United States are embolism, that is a blood clot, mostly going to the lung or to the brain, causing a stroke, severe bleeding after childbirth, hemorrhage, and pregnancy-induced high blood pressure, preeclampsia. That are the things that women are dying from in the United States. 60,000, the number of women who nearly die during pregnancy or childbirth every year in the U.S. And this is really interesting because I know in the past 6 months of 2 people who have had friends who died in childbirth. To us, when you think about childbirth, do you think about women dying anymore? Do you really think about that this was something that happened back in 1915, and that is just not the case. The mortality ratio has more than doubled since 1990, and the United States global rank based on maternal mortality is 64th in the world. We are behind every other developed nation when it comes to maternal mortality, which in 2016 is absolutely unfathomable to me. So Merck is looking at strengthening community initiatives, implementing standard approaches. There's a lot of work that the students are going to hear when they go into their maternity course next semester about evidence-based practice and things that are being done in the United States, and I'll talk a little bit about some things that I'm involved in at the national level. So Merck has something called a pep talk. So this is where I come out to you as consumers and say, all of you will know someone who is pregnant at some point in time. Many of us have been pregnant. Many of us have friends who are pregnant. But what's really important is remember the 3 core causes that I talked about maternal mortality. Preeclampsia, embolism, and postpartum hemorrhage. And this massive project is that you give your friends a pep talk. That when you talk to people who are pregnant, you explain to them, and if anybody would ever want this, I'm happy to give it to you. The students will probably get it in their course. That you explain to people who are pregnant what these different things are, what the signs and symptoms are, and when to call your doctor. I'm part of the Association of Women's Health Obstetric and Neonatal Nurses, and we are part of this collaboration with Merck for Mothers. And we're actually, I was just on a national panel that we are putting out guidelines for women for when they leave the hospital to have more clear kind of instructions on what to do if they experience these signs and symptoms. Because right now we send women home, number one, we send them home 24 to 48 hours after they've had a baby, 72 if they've had a C-section and they're lucky, and C-sections is a whole other thing I want to talk to you about. And we send them with this stack of paper. Have you ever bought a prescription lately? You know, you get a prescription for Tylenol, something with Tylenol in it, and it's 10 pages long. It's written at a level that those of us even with doctorates can't understand. I mean, who ever reads that? When was the last time anybody ever read that? We've done good consumer on it. Then we give them all these printouts of things they need to remember about their baby and this, that, and the other. And oh, by the way, sign here that says that we told you about the signs and symptoms to call for, but it's really not clear enough. So it's called the Empowering Women to Seek Needed Care Project, and these new discharge instructions that are coming out that we're hoping will be adopted nationwide will really focus on women identifying the signs and symptoms of these things in the postpartum period. So there really is a lot of work going on to try. So patient education isn't a hallmark of all of us in nursing, but that's really what we need to push for. Now, has anything I've said so far surprised you? Yeah. Women dying of childbirth, and it's just, it's just bizarre. So the pep talk. Let me tell you some Louisiana, some more statistics now. I don't want to drive you crazy statistics. So we are one of only 8 countries in the world where the mortality rate is rising. We're 33rd of 179 countries and then 64th according to the World Health Organization. So where are we in Louisiana? The Kaiser family. The Kaisers are everywhere. She's written a book. She has a relative who just participated in the Idea Abroad, and then we have the Kaiser Family Foundation. So obviously Mary has some great connections. It'd be interesting to get her on that show where they trace, family history. So in 2013, 19% of women in this massive survey that was done by Kaiser have no personal doctor at all. Like nobody that they go see on a regular basis. Hispanic women were the largest number at 37%, African American women at 23%. 22% in the past year had not gone to see a doctor because they couldn't afford to go. Now, I'm from England. I come from socialized medicine. Never had to pay for go to the doctors in my life. Thought it was crazy when I came here and I had to see an obstetrician because we see midwives. It's like, why? I'm not sick. Totally different model of healthcare. Now, I'm not telling you that socialized medicine is doing well in England right now, because it's not. They have no idea how they're going to pay for it. But, there was never an issue. If you got pregnant, you went to the doctor. If you got a cold, you went to the doctor. You never had to worry how much it was going to cost you. C-sections. Louisiana in 2013 we were at the top of the list, but not in a good way. We had the highest C-section rate in the country of 38.9%. The highest in the country. 32% of women in 2013 had their first C-section. And you're like, okay, why are you talking about this? Because some of these things are directly related to major surgery. So one of the things that they're looking into right now, the women that are dying, many of them have had a C-section. So there's a huge push from all different kinds of organizations, including the American College of Obstetricians and Gynecologists, to decrease that very first C-section. Well, why is it important to decrease the first C-section? Because here in the United States, we are so fearful that something bad will happen. 97% of women who have the first C-section will have at least one more. We're not promoting vaginal delivery for those second C-sections. Why is that? Because the physicians are afraid they're going to get sued. So this has been a huge issue that has been going on since I went into labor and delivery nursing in 1992, but we're now starting to pay more attention to it. The Alliance for Innovation on Maternal Health is a national project that is looking towards improving outcomes by decreasing primary C-section rates, decreasing the number of women who die from postpartum hemorrhage. That's one of 2 of the 7 bundles, and I am the Louisiana representative for AIM in Louisiana. Louisiana DHH applied to be part of this national project, and we were accepted into the project last year. So hospitals, we're going to start tracking a lot of these things and put things in place in hospitals to try and decrease that first C-section. Because if we can decrease that first C-section, we can decrease her risk factors, especially for embolism and postpartum hemorrhage. When we go back and look at our women who are the most at risk of dying, our African American women, okay, they're much more likely, and Africa can tell you this, to have diabetes, to have chronic hypertension. Chronic hypertension, often in pregnancy, leads to preeclampsia. So if we can identify these things before they get pregnant, manage these chronic conditions, encourage early prenatal care, then we can go ahead and hopefully decrease the chance of women dying from preeclampsia. Okay, so it's really kind of a circle. It's a circle, and there's no exit and no end point. It has to be continuous. Another interesting statistics from Kaiser Family Foundation, and they do every individual state. In Louisiana, of all the women who got pregnant and who were in the survey, and there were a huge amount of women, and they also looked at birth certificate data. Only 47% of the women who got pregnant intended to get pregnant. So that means we have 60% of our population that are getting pregnant due to unintended pregnancy. Good news for Louisiana, we used to have the highest teen pregnancy rate. We actually went down last year. So that's good. So we're doing something good. So, this is kind of where we are. And then I had to get on my soapbox about one thing that's totally unrelated to that for all of us who are women here. So you see this map. How many weeks do other nations get compared to the U.S. on paid maternity leave? Here we are. 0. There is no such thing as paid maternity leave mandated in the United States. We know that if moms can stay home with babies and be attentive to babies, it increases bonding and attachment, and it can increase the length of breastfeeding rates, that we would have better health outcomes in our children. We know moms who go back to work sooner are more at risk for postpartum depression. We know moms who go back to work sooner are not going to continue to breastfeed their babies. So this is a whole another issue related to not necessarily the people as far as, and I guess you would call it a disparity. I wasn't going to call it that, but I think it would. This is kind of, you kind of want to go down that road and say, you know what, you are punishing us for choosing to work. In this society where most of us are two-parent working families, again, a huge health issue. My cousin who got pregnant works, she's a manager at a bank, 24 weeks, her 100% paid maternity leave started. She got a whole year off, full pay, and then she was able to do another 6 months at part-time pay. And here in the US, we get 0. So I think that's a really sobering thing too. And I think my whole point is, this is a huge area that we need to work on. If the only thing you take away today is to maybe Google Mark and pep talk and find out what the pep talk pieces are, and when you see people say, has your provider told you these are the signs and symptoms you need to look for? Because if we don't educate our patients on that, we know today you try to get an appointment at the doctor's office, doesn't always happen real quick. So that's it's kind of depressing. This section that we're doing is kind of a little bit depressing, but I really wanted to focus on maternity here because I just think it's something that we don't think anymore. We think we're the United States, we have the best outcomes. It is great to have a baby in the United States, but right now we have so far to go. So that's my whole. Thank you. There's several reasons for that, and there's a lot of evidence out there. One of the biggest things was one thing I didn't talk about is that our induction rates, people being induced for childbirth, are also in the 40 and 50% range, and we know that being induced also increases your risk of a C-section. So that those two are definitely tied together. There's a national initiative through A1 and even ACOG is a part of that called Go the Full 40. Encouraging women to go 40 weeks. We really kind of got in a phase of about 10 years where it kind of became in vogue, so to speak, to have the baby on the same day as your other person's birthday. I want to have my baby this day because my mother can come in and be with me. I don't want to wait till 40 weeks because I'm really tired of being pregnant. And so the induction rates have gone up, and induction rates and C-section rates are tied together. We know that. So, there's also the litigious side of it, unfortunately, that the physicians kind of really have something hanging over their head now. That, you know, if we don't do what the patient wants, if this patient is saying, then we went through the whole issue of the designer C-sections, of the, well, I would rather have a C-section because that way everything down there stays the way it's supposed to be and doesn't get stretched out. We went through that phase in the 90s. So there's a whole host of reasons why the C-section rate is going up. So we're really making something of it. Right. Good question. Remember what I just said when you have to do the project.
Okay, we're going to go ahead and get started. My name is Dauphiney, and I would like to thank everyone this morning for taking the time to come out and be present for this particular panel. I'm the supervisor and nurse practitioner for St. Bernadette's Community Clinic here in Lafayette, Louisiana. Always like to give a little background history on who St. Bernadette's is. It's a clinic owned and operated by Our Lady of Lourdes Regional Medical Center. I have the privilege of taking care of the homeless, the uninsured, and the underinsured in Lafayette and the surrounding parishes. I guess I clicked the button, guys. What impact does St. Bernadette Community Clinic have on our community? The clinic is a necessary safety net for individuals experiencing the inability to access health care. Access to health care is a huge issue and concern here in the United States of America. Provides approximately 3,000 medical visits per year, valued at about 1.5 million each year on the services that we do provide. In 2015, the clinic provided 438 dental visits valued at about $200,000. So it costs, guys, as you all can see, for healthcare. This is just a brief summary of some of the clinic demographics. The majority of our patient population are from Lafayette Parish. Gender distribution, 63% are males, 25% are females. Insurance status, 61% of our patient population are uninsured, guys. There are a ton of uninsured individuals in Lafayette and the surrounding parishes. And the educational level, because that makes a big difference. People sometimes, well, why do you have that there? It's on how you approach patients, what you present to patients, and how you communicate with your patients based on their educational level that they have. One question that I'd always ask or begin my talks with, how many states are in the United States of America? Any hands? Yeah, 50. But I always set this as a precedence as we move forward into the PowerPoint of why this is important. So you can see where we stand in relation to other states here in the U.S. Health disparity, breast health. Louisiana ranks 47 in deaths due to cancer, and we have 50 states, so we're at the bottom, guys. Breast cancer is first on the list for the top 10 cancers diagnosed in Louisiana. Breast cancer deaths per 100,000 women is 24.2, and the United States rate of 21.3. So we're up there, guys. And African American women incident rates are 134.6 in Louisiana compared to 120.1 of African American women in the United States. You heard Dr. Hurst mention African American women. There are disparities within disparities. Women have disparities as a whole, but then African American women have it even worse. Some of the things that we do at St. Bernadette to provide access to meet that need. St. Bernadette's provides the following breast health in 2015. 140 breast cancer screens, 64 were given access to mammogram or diagnostic studies for breast health. And I'm a numbers girl, as you probably can see. You have to know where you are to understand where you need to go and what goals you need to meet. Cervical cancer, another health disparity. Cervical cancer incidence rate per 100,000 women are 8.4 for Louisiana, 7.4 for the United States. African American women incident rates are 11.3, when compared to 9.0 of African American women in the United States. Cervical cancer is 8th on the list for the top 10 cancers diagnosed in Louisiana for African American women. It's not even on the list for Caucasian women. So we're dying from something that's very preventable. Access to care at St. Bernadette's for that particular issue. St. Bernadette provided the following reproductive health. 122 women were screened for cervical cancer. And I started at St. Bernadette's in about 2012, and I tracked from that point on. So in 2015, we're at 61% of the women were screened for cervical cancer, and we started at 45% in 2012 when I began there. Sexual health, sexually transmitted diseases. People don't like to talk about it. When the students from UL come, it's awkward, it's strange, to people to ask about your sexual health when you're having sex with men, women, it is really awkward, but it has to be addressed, guys, because we have really horrible numbers. I hate to be the bearer of bad news, but we do. Louisiana ranks 3rd highest in chlamydia cases. We have 50 states, we're at the top, 3rd. Louisiana ranks 1st in gonorrhea cases. Louisiana ranks 2nd in syphilis cases. And mind you, we have 50 states. St. Bernadette provided the following for sexual health in 2015. 267 people were screened for sexually transmitted infections and also treated if need be. And it started 5%, we're up to 14%. And all of this collaborations, the Department of Health and Hospitals, the local public health, they're inundated. They can't keep up with the number of people that come in. They send them to us. Dr. Stefanski, I love her. We have a great partnership and collaboration. So they come see us at St. Bernadette's. HIV, guys. Louisiana ranks as the third highest for HIV case rates out of all 50 states. African Americans in Louisiana are experiencing a severe health disparity in regards to HIV and STDs. 29,948 collective cases have been detected in Louisiana, including 292 pediatric cases as of June 30th, 2015. And 29% of the women in Louisiana have HIV. Until you know your numbers. That's why it's important to know where you are. St. Bernadette provided the following screenings for HIV in 2015. 211 patients were screened for HIV and given education on sexual health at St. Bernadette's. Heart disease and stroke. Louisiana ranks 46 in death due to heart disease and stroke. Heart disease is the leading cause of death in women in the United States. Heart disease is the #1 killer in Louisiana. We're dying, guys. St. Bernadette, again, we believe in partnerships, collaborations. It takes a team to get it done. St. Bernadette's provided the following heart health clinic. 3 of them in 2015. I wrote a proposal to Heart Hospital of Lafayette to get this particular clinic started, and it has been amazing. We have an ultrasound machine, Dr. Wojak, who's an awesome individual. She's an interventional radiologist and top notch in her field. And during the heart health clinic, she comes, she gives of her time and of herself, guys. And if you Google her, you'll see why I'm saying top notch. But at the Heart Health Clinic, diabetes screens, stroke assessments, cholesterol screens, carotid ultrasounds, ankle brachial indexes, and consultation with the interventional radiologist. These things cost, guys. It costs. And that's just a picture of some of UL students. We have the privilege of having them at St. Bernadette's as well on Tuesdays and Wednesdays. It's a part of their community rotation. Louisiana, obesity and diabetes, guys. Louisiana ranks 45th in the percentage of obese adults. And again, I'll remind you, we have 50 states. So we're at the bottom. Louisiana ranks 45th in the percentage of adults with diabetes. And 36% of the women in Louisiana are obese. And I tell my patients all the time, I'm not exempt from that exclusion. I fall into that category. And it's a work in progress. It's something you have to work at every single day. St. Bernadette provided the following to help curtail obesity and diabetes in 2015. In 2014, I wrote a grant for a nutritional health program. I'm one of those providers, myself and Ms. Bridget, who's here at St. Bernadette's. We would tell patients, cut back on your carbs, cut down on sodium, and we knew they had food disparities. And I do not like giving a patient a treatment plan and knowing they cannot fulfill it. So I came up with the idea, collaborated with Lafayette Catholic Services. They changed their name, guys. And I tell Kim all the time, Kim Ritter, she's the executive director. Forgive me, because y'all just changed your name. But it was Lafayette Catholic Services. And I presented this idea to her. What if we, get a full-time cook, full-time clinical dietitian, and we purchased the majority of the food for St. Joseph's Diner. I applied for the grant, wrote the grant, and got it. And we hired a full-time cook, full-time clinical dietitian, and purchased the majority of the food at St. Joseph's Diner. Blood pressures have decreased, guys. Education for us, nutritional health has changed. So you're making a difference and outcomes are there. I keep having to go back. 71 patients receive nutritional counseling by a registered dietitian. 111,141 healthy meals were provided in collaboration with St. Joseph's Diner on last year. Thinking outside of the box. What things can you identify in this particular slideshow? We're quiet today? I like to talk. Well, what things have y'all identified? Well, there you go. It told you. I should have said it slow. Collaboration, partnerships, identification, implementation, action, and evaluation. You know, I had the privilege of being on the steering committee for the Louisiana State Health Improvement Plan. And one of the things, you know, Dr. Hall, we were commissioned to review this particular document, you know, regions met and that kind of thing, and came up with an improvement plan for Louisiana. And when I started going through the document, I was like, oh my God. You know, African American women come up, you know, disparities within disparities, like I mentioned, you know, and it's like, okay, we've identified, we've been knowing about this for I don't know how many years. And I had to call up, I'm like, Dr. Hall, am I moving in the right direction? Because the document was read. And I'm one of those, when do we get past identification, guys? That's my call to action for people. We know that there's a problem. We know it exists, and it's not just because I think it exists. The data, the numbers, the statistics, they're there. When do we get past numbers and identification and move into action? That's what I'm calling everyone in this room, in the sound of my voice, to action. We have to think outside the box. We have to cross over lines that we may not used to crossing over to. I never thought I would be nutritional health and diets and looking at menus and thinking about things of that nature, but in order to become a part of the solution, you have to think outside the box and talk to people and pick up the phone and conversate with people that you may not normally engage with. So again, step outside your comfort zone. And let's not turn our backs to the concerns of women in our community. That's why I had the women in the PowerPoint turned around. Any questions about anything? Questions, concerns? I have some flyers about St. Bernadette's, what we do, and the services we offer, the times and the dates, and I'll pass those out. And if anybody wants a card to call me up, have a question, I'm always here. Yes, ma'am.
Just to take, say, cancer as an example, I mean, what are the causes of higher rates of cancer in Louisiana?
And let me tell you, I'm one of those, I analyze, I look at patterns, I look at trends, you know, access, feeling comfortable, and I will say, as a provider at St. Bernadette's, being in that 70501 community, which is predominantly African American, they distrust healthcare, and I'll have to be just totally honest with you. They distrust healthcare. They don't see many people on the other side of the table that look like them. And they, you know, because of historical, you know, issues, because I ask, I'm one of those kids or people, you know, I've been like that, to ask and try to figure out why it's an issue, it's a concern, so they don't seek access. And I try to explain to my women that do come in, because we get a large number of them that's never had a mammogram. And they're over 50 years old, never had a mammogram. You know, and I try to explain to them, you either go in on the front end or the back end. If you go in on the front end, it's usually on your terms. But if you go in on the back end, it's usually you don't have any control, and the outcomes are usually not good. So you have to meet them where they are. And just another example, the nutritional health program. I was running a chronic kidney disease clinic for Our Lady of Lourdes, and I got a dietitian for that particular program as well. I asked the question, and I'll ask it in this room. We have some healthcare professionals. What's a 2,000 gram sodium diet? Can you tell me what that is? Can you show me how much that is? And let me tell you guys, I ask this question often. Healthcare providers cannot tell you or show you what it is, but we give those instructions to patients every day, and we expect them to lead and be successful. What are we setting them up for? So that's, yes, ma'am.
I just wanted to bring up how, if somebody's on a limited amount of food stamps and they're trying to feed themselves and their family, unfortunately, the healthy foods are more expensive.
That's right.
than processed foods, you get the cheapest foods because you get more.
Exactly.
Just really.
Exactly, and that was one of the reasons, in my journey throughout nursing, I took the word non-compliance out of my vocabulary. And the reason being is I found in my time, there's usually a reason why they're non-compliant. Do they have access? Is it acceptable to their culture, to their community? It's usually a reason of why they can't do what you're asking them to do. So the philosophy of non-compliance, I try not to judge patients on that particular area or concern. Yes, ma'am.
So much of it, and we all know this, so much of the culture and the economy is based on food here, and it's not grilled fish.
And this is the thing.
It's like you're fighting a losing battle.
We have our own culture, but this is what you do. The dietitian that I hired, and I set out expectations and goals that I had. I'm going to tell Mr. John, if I tell Mr. John to stop eating all this boudin, what's the likelihood he'll do it? I'll eat 3 days. That's right, slim to none. But if you tell Mr. John, I want you to cut back to 1 lick of boudin every month, what's the likelihood of him doing that? It's greater than telling him he can't have it at all. Because this is a culture, guys. I'm a part of it. I love to eat, drink, and be merry as well, as you can tell. So you have to engage patients and individuals where they are in their communities and be culturally sensitive. The other thing is people think when I say cultural sensitivity, then I'm talking about race. No, cultural sensitivity, their communities, access, medication, money, being just culturally sensitive to their being, their situation. Not just their race. Do they have places in their community where they can get fresh produce? Do they have access to, medications in their community? So it's just looking at life and things from a different perspective. Where am I on time, Jennifer? Any other questions? And I know Dr. Hurst and Ms. Judith Perez, they're some awesome individuals.
Y'all for mental health services?
Mental health, okay, that's another.
That's a whole
That's a whole other thing. Everybody has a mental health bank. That's how I look at it. And a number of patients that come in have mental health issues, and we address those concerns to the level of our ability. And it's again having that conversation and helping people to become comfortable with their practice and who they are, because we don't have enough psychiatrists and psych NPs and counselors and social workers to address the needs of mental health. So as providers, acute care, chronic adult, family, you have to be unafraid to address those issues. You have to be unafraid to look at the person as a whole being and understand that, women have anxiety and depression. Usually they go hand in hand. I've noticed that through patterns in situations in life, and you can't ignore it. We'll treat acute issues, but chronic issues we try to, we've identified community resources where we can, gear them to, but education, trying to understand where they are, why they don't take their medicine, because they don't like the side effects, but to ask them about it and not shun them when they do respond, saying and telling you, I'm not taking my medicine this Africa. Well, why aren't you taking your medicine? Instead of saying, no, you need to take that medicine now. We beat people up. We truly do, guys.
That's a great question about mental health, because not only is that something a Louisiana issue, but nationwide, we do not have enough psychiatric mental health care providers. And, to relate that back to maternity care, we have lots of OBGYNs that are prescribing all kinds of psychiatric medications, but have never sent their patients for a true psychiatric evaluation. So, you also have kind of like this, okay, should you, if you have a person who you think has depression or you think have anxiety, they would be better off getting a thorough screening by a professional, because a psychiatrist is not going to take care of your maternity problems. So OBGYNs are really not the best person to take care of psychiatric mental health problems. So we have a whole issue with people being prescribed medications by providers who that is not their primary focus, and are not getting the follow-up, and perhaps, okay, well, yeah, I give you a pill, but really for what you have, you really need some form of psychotherapy in order for, that's what the evidence says. So that's just a huge issue in and of itself, and I think Africa made a great point about the, about, number one, calling our patients non-compliant, because that has such a negative connotation. And like she said, 9 times out of 10, there's a reason why they're not doing it. Not because they just don't want to and want to be awkward. And when we use that term, it really does that. And then in the case that there's usually a reason why they're not doing that. And you all know what it's like to go to the doctor's office. You go and you sit there for an hour and a half, and they walk in the room for 5 minutes and ask you about that one specific thing you're there for, and walk out the door. Where's the whole taking care of the whole person? And if you, and that's the issue we have with medications, and Africa can tell you, she probably sees people that have prescribed all different kinds of medications, but might be seeing several different practitioners, and this is especially been prescribed twice.
Talking, so and the patient doesn't know, have an opinion, you're right, they think, oh, that's just 2 different drugs.
And then you have people who have insurance, who they have an OBGYN, they have a pediatrician for their kids, they have an internist, a cardiologist, a neurologist, but there's no crossing over of health records. So then we get interactions with medications that promote side effects, but there's no integration of the healthcare system.
And the pharmacist is going nuts.
Yes, absolutely. Absolutely. Yes, our husband's a pharmacist. It's just...
Okay, guys, so I'm going to let, is Ms. Judith, so she can come up and talk. If anybody has any questions after the panel, I'll be here and to answer those.
Thank you.
We told you this was going to be a depressing session, because we're talking about a lot of negative things, Yeah, but realizing what we need to do to make things better. We kind of, where we are in Louisiana, unfortunately, we kind of have nowhere to go but up in a lot of these areas, so,
I think one of the things that really, I'm very much aware of is that there's not enough time. This is a very short period of time to talk about some very important issues, some very sobering numbers, and some very scary outcomes that are happening right now. What we really need a lot of time to talk about is what we can do about it. And there's a lot of power in this room. There's a lot of women power in this room. Gentlemen, forgive me. My name is Judith Perez, and I am the Director of Clinical Services at the Lafayette Community Healthcare Clinic. For those of you who are not familiar with our clinic, it is the free clinic in town. When people hear free clinic, they might think 60s, we're not quite there. And they may think maybe lesser care, which is so not true. We are different from St. Bernadette's in that all of our care is provided by volunteers. All of the providers, which are physicians, nurse practitioners, and I'm happy to say we have some UL nurse practitioners that are seeing our patients. All of the nurses, dentists, pharmacists, just about anybody and everybody that touches the patients are volunteers. There's only a couple, 3 of us that actually work there and get money. I'm the only licensed person that's there. We are different than a federally qualified clinic in that we get no federal or state dollars. All of our money comes from from volunteers, obviously, but donations, grants, and fundraisers. So you can imagine the dollars are very tight. So some of the things that we provide, and since we're talking about women, I'll just start off with that. People think that a lot of our patients maybe well, I'll just say it. Our patients are poor. They're not dumb. These are some very smart people. These are folks that have managed to stretch a dollar and make it scream. They have put food on the table, kept electricity on, have fed their children, gotten them to school, and sometimes they work 2 and 3 jobs. They just don't have insurance. So, as nurses, it's like, this is great. I mean, my job is wonderful. I get to teach, I get to take care of people, I get to teach people how to take care of themselves, how to take care of their families. So it's very exciting in the way of being a nurse. In the old days, and I'm sure some of the more mature nurses in the group will remember this, we used to tell people, as Africa had mentioned, don't do this, don't do that, do this, do that. Well, now I tell people, I'm not your mama, I'm not your priest, and I'm not the police. Tell me what you really do. Well, do you drink? Well, maybe every once in a while I have a glass of wine. Do you drink? Well, okay, yeah. I have like 3 glasses of wine every night, and I eat this, I do that. Well, then that explains that A1C of 15. Why your blood sugars are so high. Let's talk about that. I'm not going to make you quit drinking, but we're going to talk about what it is that you're doing and how we can adjust it, okay? In the old days, we told people, don't ever eat sweets if you're diabetic, right? Do not eat sweets. So what do? Go home and eat a pie. So now we say, you can eat anything. You can have a piece of pie, not a pie. And people tend to do better with that than you can't have it. You tell me, and I'm supposed to be, well-educated nurse, blah, blah, blah. I'm going to want it. That 3 links of Buddha, that's me. But if you tell me I can have a piece of something, I'm going to have it. And that goes so much further with patients. And then you get them to participate in their care. So if they're participating in their care, the chances of them following along with it are way better. Yeah? So that's what we want to do. And as we're bringing new nurses into the tribe, we want to make sure that you understand that you go where your patients are. There's some patients I will refer to as Mrs. Jones forever, even though she may be younger than me, because I know that's where she's at. I know I'm entering with a privilege, but okay. I know that's where she's at, so I'm going to talk to her in that way. Some patients, hey girl, if you don't stop doing that, you're going to die. And I can talk to that patient that way, because that's how she's going to hear me. So that's the puzzle, is finding out where your patient's at so you can speak their language. Some people will not hear you if you don't turn that key, find the right key to turn them on to hear you. So getting back to our clinic. We offer women's services twice a month, where you can see a gynecologist or you can see a nurse practitioner who specializes in women's health. And one of our biggest providers from UL is Dr. Linton. I just want to give her a shout out there. Where you can get a thin prep is what we do. And you can also get an order for a mammogram. And then all of the results come back to us. They do not go out to the providers that see our patients, because it could be Dr. Stormont who's over here, and if he gets all this stuff, then he's just going to have to come back to us to tell us what to do. So we get all the information on those results, on those thin preps and mammogram results. Then we call the patient to come in and talk with a provider if that's necessary. If it's normal, we call and let the patient know that it's normal. We see a garden variety group of people. We see people of color, we see Caucasians, we see males, we see females. It's garden variety of people with a garden variety of any kind of chronic illness. From diabetes to high blood pressure, asthma. These are the three biggies that we see, especially in South Louisiana, that asthma, especially right now. We do not see pregnant women. We do refer them to La CHIP so they can get the services that they need. I have a brochure that will give you some of the information that's needed for patients to access our services. Some of the things are you have to be at 200% or below the poverty guidelines. And I don't know if you guys are aware of this, but the feds put out a chart every year. 200% of the poverty guidelines is nothing. One person in a household, maybe $23,000, don't quote me, but it's about $23,000. When you start looking at rent and food and gas and all these things, it's nothing. And most of the times we have 3 people in a household, maybe 4 people in a household that are living on $24,000. So we can offer them an opportunity to worry about one less thing, and that's about their health. They can see us, they can see a provider. We're open 2 evenings a week. You can get pharmaceuticals. We have a limited formulary, but we can cover pretty much every classification of meds that are needed. We have a strong PAP program, pharmaceutical assistance program, a patient assistance program, to get some medications that are very costly. I don't know if anyone in here has any idea how much Levemir costs, which is a type of insulin. Okay, it's a little vial about this big. Yeah. $395 for a vial. Okay. Advair inhaler, you see, okay. $480. Yeah, right. For 120, okay, little, squirts. And I happen to know that because I was in between insurances and had to pay for it. I'm blessed, and I had a credit card. Our folks don't have that. So we really utilize those pharmaceutical access programs very generously. Let's see. We have nutritional counseling for our patients. It's once a month, but we have a nutritionist that comes in. We have a certified diabetic educator that'll see our diabetic patients once a month also. There's a lot of things that we cannot provide, and those are more of the diagnostics, things like MRIs, CAT scans, so we do refer people to UHC. One of the things that I did not know about UHC was that when you apply for free care, it's an all or nothing deal. I don't know if anybody knew that. It's not a sliding scale, which for years I thought that's how it worked. You either make the cut for free care or you do not. So if you do not, then you're paying full price as anyone else would. So, but most of our folks, again, do apply for free care at UHC to have those diagnostics done. And they make the cut, for lack of a better word, because they're at 200% or below the poverty guidelines. I digress, and I apologize. So getting back to the eligibility criteria, 200% or below the poverty guideline. You have to live in Lafayette Parish, and you have to be working. And that's the real big difference between like St. Bernadette's and our clinic, is that you have to be working to be a patient there. There's some things that would exclude you from being a patient at the clinic, and some of those are if you're involved in a lawsuit, health lawsuit, or you're not working, or you have a disability that would keep you from working. I mean, we have folks that we have a hearing impaired person, which was considered a disability, and but he's working. So, and he doesn't come to us for his hearing impairment. Okay, so that's about that. Getting back to the other services that we provide, we also have a dental clinic where we do cleaning. We have the LSU Hygiene School in our clinic that's housed there. So patients can be seen during the daytime. If you want the best cleaning of your life, have a student do it. They're getting a grade, not money. Way more important. And then if they miss something, the teacher's right behind them to pick it up. So best cleaning ever. We also will clean teeth once a month in the evening, because we see people in the evening because they're working during the daytime. And our biggest thing is to keep people working. Let's see, right now we do extractions, getting people out of pain. Unfortunately, we do not have a restoration clinic, but who knows what could happen. Let's see, vision. We have a virtual vision clinic for our patients that are diabetic and hypertensive, as you know, to chronic diseases that can cause blindness. We have other providers in the community that will see our patients for free. And if not, then again, we'll refer them to UHC. We've also had to refer folks to New Orleans, to the new medical center there, because, as you know, Africa, there's a waiting list for dermatology, let's say, that could be 6 months to a year. So it's much shorter in New Orleans.
To speak to that also, it brings up in mind the expansion, the Medicaid expansion here, that John Bell, that'll be taking effect, shortly. I'm ecstatic that it's occurring, but people also have to understand the other side of it. There's an expansion, but there's no one to see those individuals.
Okay, so
there's no providers to see those individuals, and like Ms. Judith said, they're having to go outside of their community, and a lot of them don't have transportation. Guys, believe it or not, in this day and time, they don't have the means to make it there. So we have Medicaid, a form of payment, but who's going to see those people? Who's going to meet the need?
It's a wonderful thing that people will have more access to health care. And as well intended, I think, as the Affordable Health Care Act was, it's people, our patients, some of our patients have bought this insurance. And what they have is an insurance card. They do not have access to health care. A lot of our patients, a patient that was coming pretty regular, I hadn't seen him in a while, and it's like, oh, hey, John, how are you? And where have you been? He goes, well, I bought insurance. And it's like, oh, well then what are you doing here? Because you can't have insurance if you come to our clinic. And he said, well, I gave it up because I haven't seen a doctor or had medicines in 6 months. And he said, well, my deductible's $6,000. If I had $6,000, I wouldn't come to see y'all. I would go see a private doctor and buy my own medicine. Oh, so this guy's asthmatic. He hasn't had his asthma medicine in 6 months. He's a mess. So he gave it up. So again, having a health insurance card in your wallet is not having access to health care. And I think that's sometimes what people really, it's misleading.
I think that's a really good point, because people don't understand what insurance is being offered through the Affordable Care Act and Obamacare, because it really is. If you ever go online and look, I'm kind of interested to see how much it was. Mm-hmm. So I go online and I put in, some fake numbers and stuff. And when I looked at the plans, the cheapest plan might be $50 a month, but you have a $6,000 deductible. So who can pay for that? So, we have this idea out there that it's really covering people. And yes, we're mandating, because you get penalized on your taxes, that you get it. But the plan you can afford, you still maybe not be able to afford health care. And I think people don't understand that.
And also on that, along those same lines that people don't understand, they may have insurance that's affordable through the Affordable Care Act, but providers
Don't
are
take
not accepting it.
And then there's that piece.
Yeah, I had a friend the other day, her daughter has just got off their insurance, she's 27, and she's pregnant. But she signed up for Obamacare, she's got a Humana card, but she cannot find an obstetrician to take the Humana card
That's
in
right.
Lafayette.
Yeah.
So, okay, now what? There are so many issues, surrounding all of this.
People keep asking us, with the expansion of Medicaid, with Affordable Health Care Act, are free clinics still needed? And of course, we're going to say yes. Yes. We see a niche group of people. We see people who, are traditionally called the working poor, who are traditionally called the people that fall through the cracks. We see a niche group of people, and whether it's 1,000 or 100, there's still those people that need to be seen. I think everybody knows the starfish story, right? Of the guy who's walking down the beach and he sees all these starfish laying on the beach, and he's running around trying to throw them back into the sea. And someone came up to him and said, "What are you doing? This is hopeless. You're not going to save them all." And he goes, "Well, I saved that one." So that's what we're doing. We're saving that one, and that one, and that one. Maybe not all of them, but we're going to save as many people as we can. Thank you so much for allowing me to come and talk with you today. Does anybody have any questions about our clinic? Thank you. There's some information up here for you.
Actually, I do have a question.
Yeah.
How do people who are not healthcare professionals support you? What
Any
can we
number of
do?
ways. Any number of ways. Obviously, about donations. Grant writing, if people are very good at grant writing, we can always use some help with that. We have a signature fundraiser, the Silver Bell Soiree, at the end of each year or the beginning of each holiday season, where people can help us with that, to be on that committee, where we have silent auction items we look for people to sponsor. Even if you're not a healthcare provider, people think if you're not a licensed person, then you don't need to volunteer, you can't volunteer. Oh yes, please. We have volunteers that work in medical records, we have volunteers that just do all sorts of things. I'm leaving my card here as well, so if anyone has any burning desire to come in and volunteer with us, I encourage you to do so, to call us. We have UL nursing students that come with us to see us and help out. We have South Louisiana Community College nursing students that come to volunteer with us. It's a great place, as we have talked about. Michelle Broussard and I talked about this more than once. We have senior nursing students that volunteer with us. And it's like they get to learn their pace, on how to talk with patients. The instructor's not, breathing down their neck. They forgot this, they forgot that. And because when anybody who's an interview, I know Margaret, you're a therapist, it's like you don't go down my name. You do a conversation with the person, and you find out all kinds of things that aren't on your list, right? So that's what the nursing students are learning how to do. They're learning their pace. And when Cindy Watson, who's also one of our providers, nurse practitioner from here, she said that you'll listen to them and it's like, oh my gosh, they're like, they learn their pace. They learn how to talk to patients in a very more relaxed environment than maybe at the hospital. It's just a really great place. Nobody's there because they don't want to be. Did that make sense? Okay, yeah. Okay, everybody's there because they want to be there. And it's just really a very, very warm, environment. And patients come in, and nobody wants to feel as though they're walking in with their hat in their hand, and getting charity. It's like the presentation is, we've been waiting for you. I'm so glad you found us. God knows you're sick, and I'm so glad you found us because we can help you. And that's the feel. That's what we want to extend to people, not like, he's so non-compliant.
And to, I guess, add to that, and I can definitely attest to that, because St. Bernadette's, if you've ever been there, it is an immaculate clinic. And when patients walk in, they usually stop and pause and think, is this the clinic? Is this where I should be? And to think in 2016 that people think just because you're receiving free care, it should be substandard or subpar care.
Exactly.
They're amazed that this clinic is for them, and the quality and the way it looks and the care that they receive. It just shocks me even to this point that people would think just because I don't have insurance or I have Medicaid or Medicare and the care is free, that something should be wrong with it.
I think we work harder at it because we are free to make sure that does not come off, that you're getting something less than you would at the paid doctor's office. Again, I thank y'all very much.